Dr. Baliga here. The case scenario or multiple choice question discussed in this podcast is derived from an outstanding chapter on patient safety in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It's authored by Dr. Anjala V Tess MD, who is Associate Professor of Medicine at Harvard Medical School. She's a hospitalist in the Division of General Medicine and Primary Care, Department of Medicine at Beth Israel Deaconess Medical Center, Director of QI and Safety for GME at Beth Israel Deaconess Medical Center. During her second year as a hospitalist, she served as a Rapkin Fellow in Medical Education. She served as an Associate Program Director for the Internal Medicine Training Program, where she was in charge of quality and curriculum development. As a hospitalist, Dr. Tess currently teaches on medical wards and is Director of Education for the Hospitalist program. Dr. Eric J. Alper, MD, is Professor of Medicine at UMass Medical School. He completed his medical training and internal medicine at UMass Medical School. In 1996, he became the first hospitalist at UMass Medical Center and helped to create the Hospitalist program there. He was the Internal Medicine Clerkship Director from 1998 to 2007 and Patient Safety Officer for UMass Memorial Medical Center from 2003 to 2006. A 73-year-old woman with hypertension and atrial fibrillation who lives in a skilled nursing facility develops delirium. A urine analysis reveals 105 white blood cells. Trimethoprim sulfa 1 double strength PO twice a day is prescribed by telephone. 3 days later, the patient presents to the ED with grossly heme-positive black stool and is found to have a hematocrit of 21. Her INR is greater than 7.5. On detailed review of the patient record, the provider realizes she is also on warfarin. He states that he was not aware that the patient was anticoagulated. Which of the following systematic interventions would be strongest at mitigating harm from drug-drug interactions in patients on warfarin? A. Placing a sticker on front of a chart that says patient on anticoagulation. B. Enacting a policy that states all medication changes in patients on warfarin require a repeat INR in 2 days. C. Educating nurses and physicians on common drug-drug interactions in a monthly seminar series supported by signage and charts and in the nursing stations. And D. Automating a lab order for an INR in all patients on warfarin in whom medications that cause changes in INR have been ordered. Nurses taking this order for a new antibiotic would remind the physician that the lab testing is being sent and that the lab result is automatically sent to the provider on call. And the answer is D. Automating a lab order for an INR in all patients on warfarin in whom medications that cause changes in INR have been ordered. Nurses taking the order for a new antibiotic will remind the physician that the lab test is being sent and that the lab result is automatically sent to the provider on call. All of these interventions have the potential to improve care. The label on the chart raises awareness and this is a high-risk patient. The policy makes safe care more explicit to providers. The education program arms the providers with the information they need to manage their patients more safely. All three of these choices rely on providers to do the correct thing. The last choice, an automated lab check, and resulting is a stronger intervention because it is automated and doesn't require a provider to remember to do the safest thing. The check happens and the information is pushed to the appropriate provider to act on. Patient safety methods. The most important part of work in patient safety is studying adverse events and near misses as they occur so we can learn from them and make our systems safer. There are two main approaches to looking at error in practice. One is root cause analysis, and the other is failure modes and effects analysis. Root cause analysis or contributing factor analysis is a retrospective method where an individual case is investigated using a standardized approach to identify the active failures and the latent conditions that allowed the error to be propagated through the system. The goal is to move past the actions of just the individuals and understand how the system could have contributed to and failed to catch the error. Charles Vincent coined the term contributing factor analysis to describe the systematic approach institutions can take to analyze every layer within the system and whether it played a role. The contributing factors move from the front line of care, the patient and provider, up through the whole system of care to the level of the healthcare organization as a whole. The first step in completing a root cause analysis is to gather data from charts and interviews of frontline providers involved with the error. Then the case timeline can be organized and contributing factors identified. The team can then propose potential systems fixes to prevent the error from occurring again. Another method is to list all the active failures in a case and to keep asking why up to 5 times to determine the true root causes. This requires taking each active failure separately to identify all the root causes. A critical piece of root cause analysis work includes the interviews and discussion occurring in a blame-free manner with no risk of penalty or punishment to frontline providers or managers who are acting in good faith and without intent to harm. Without this culture of safety, providers will not feel comfortable sharing the true issues that are preventing work from occurring safely. Blaming and punishing frontline staff for system errors does not help us learn about our systems. First, the error is likely to occur again even if the provider involved is removed. Second, without full participation from frontline providers, the team completing the root cause analysis may draw the wrong conclusion and fix the wrong problem. That being said, in cases in which the provider is grossly negligent or knowingly fails to follow established policies and procedures, it is also important that providers be held accountable. Another important tool for safety improvement is failure modes and effects analysis, as this is a prospective method, not reactive. For this method, one enumerates each step in a known process and identifies what could go wrong with each step. One then assesses the likelihood of failure of each step along with the severity of a failure at that step. This facilitates calculation that calculates a priority score for each step to determine which are most critical to fix first. Once a root cause is identified, interventions can be designed to try and prevent the error from happening again. In general, weaker strategies rely on education or reminders to providers. Intermediate strategies change workflow or provider behavior, for example, checklists or protocols. The strongest interventions include force functions that don't allow you to commit the error. For example, nasal cannulas that only attach to the oxygen nozzle prevent inadvertent delivery of nitrogen. Examples of interventions to mitigate harm. Much of what is done in medicine presents risk to safety. However, there are several areas that more commonly present risks within the healthcare setting. The Joint Commission and other external stakeholders have identified key areas for healthcare organizations to target error reduction. Every healthcare organization needs to have structures in place to assure that it is delivering safe care and is in compliance with regulations. The case discussed in this podcast is derived from Baliga's textbook of internal medicine from an outstanding chapter on patient safety authored by Dr. Anjala V Tess MD, Associate Professor of Medicine at Harvard Medical School and she is a hospitalist in the Division of General Medicine and Primary Care, Department of Medicine at Beth Israel Deaconess Medical Center, BIDMC. She is also the Director of QI and Patient Safety for GME at Beth Israel Deaconess Medical Center in Boston. During her second year as a hospitalist, she served as a Rapkin Fellow in Medical Education. During this fellowship, Dr. Tess created a model to teach quality improvement to residents. She served as an Associate Program Director for the Internal Medicine Training Program, where she was in charge of quality and curriculum development. Dr. Tess currently teaches on the medical wards and is the Director of Education for the Hospitalist program. She has led faculty workshops in both curriculum development and patient safety education. She is currently co-director of SHM and AAIM's Quality and Safety Educators Academy. Dr. Eric J. Alper is MD FACP, SFHM, is a professor of medicine at UMass Medical School, where he also did his medical training and his internal medicine residency. In 1996, he became the first hospitalist at UMass Medical Center and helped to create the Hospitalist program there. He was the Internal Medicine Clerkship Director from 1998 to 2007 and the Patient Safety Officer for UMass Memorial Medical Center from 2003 to 2006. He is now the Vice President and the Chief Clinical Informatics Officer at UMass Memorial Healthcare. He has received multiple teaching awards and has been recognized for numerous quality and patient safety improvements.